What if the hospital of the future already exists and artificial intelligence is the one running it? We are not talking about robots doing surgery. We are talking about artificial intelligence that predicts which patient will crash before the monitor's alarm. Artificial intelligence that sees a global outbreak before governments do. Artificial intelligence that gives your doctor their time back so they can actually look you in the eye. That is Module 4, and it starts right now. Hey everyone, welcome back. And this is your Artificial Intelligence in Medicine series. Last module, we covered artificial intelligence in diagnostics. Now we are zooming out from the single patient to the entire hospital system. Module 4 has 5 chapters: Triage and burnout, telemedicine and chatbots, outbreak prediction, hospital resource management. One goal: to prepare you to work alongside artificial intelligence, not be replaced by it. We are building the next generation of artificial intelligence-ready doctors, one module at a time. I will see you inside Module 4.
All right, welcome back, everyone. So in our last lecture, we really honed in on how AI can help diagnose a single patient, right? Looking at that one set of scans, that one EKG. Today, we're pulling the camera way back. We're zooming out to see how AI is being used to manage the health of an entire hospital system, and even how it can help predict major public health crises. We're shifting our focus from the individual to the whole system. So here's our game plan for today. First, we're going to diagnose the problem, the incredible pressure our healthcare systems are under. Then we'll dive into the AI-powered solutions, starting right at the ER front line, moving to virtual care, and even looking at how we can predict the next outbreak. And we'll finish up with what I think is the most crucial part: your role as a future doctor in this totally new landscape. So let's jump in. You know, before we can really appreciate the solutions, we have to understand the problem. And the problem is that our healthcare system is under some serious strain. You can almost think of it as having these deep cracks in its foundation. We're going to see how AI isn't just about patching those cracks, but about reinforcing the entire structure. And that pressure, it starts the moment a patient walks through the hospital doors. This quote from ER Triage really says it all. Triage in the emergency department isn't just about making a queue. It's an incredibly high-stakes sorting problem. One wrong call can set off a dangerous domino effect, delaying care for someone who's critically ill and, at the same time, wasting precious resources on someone who is less urgent. Now, this pressure isn't just at the front door. It follows clinicians around all day. I mean, this image really captures it perfectly, the crushing weight of all that documentation. And let's be clear, this isn't just paperwork. It is a primary driver of burnout. Every single minute spent typing on a computer is a minute you're not spending with a patient. And that erodes not just time, but morale, right, across the entire system. Okay, so we've laid out some of the problems. Now let's start talking about the solutions. We're going to go right back to that chaotic entrance of the emergency department and see how AI can start to bring a little bit of order to the madness. This slide really shows the fundamental change. On the left, you've got the old way, right? A clinician under immense pressure, relying on their experience and heuristics, which are basically quick mental shortcuts. It works, but it can be subjective. Now look at the right. This is where AI just changes the game. It's not making a gut call. It's performing a super fast, data-driven analysis, pulling in 50 to 60 different data points in seconds to suggest a whole care pathway. So how does this actually work in the real world? Well, let's take that ER triage system. First, it just drinks in all the patient data, vitals, history, lab results. Step 2, it crunches all of that data, comparing it against established clinical scales. These are basically proven scoring systems for risk. And then step 3, in less than a minute, it spits out a clear recommendation. It's not replacing the doctor, it's empowering them with this incredibly powerful evidence-based second opinion right when they need it most. Now, AI's impact isn't just stuck inside the hospital walls. It's also fueling a massive revolution in virtual care, and it's completely changing how patients and providers interact with each other. The engine driving this whole revolution is something called natural language processing, or NLP. The easiest way to think about it is this. NLP is the technology that lets AI become fluent in human. It's the magic that allows a machine to actually listen to a patient describe their symptoms, understand the context and the meaning, and then respond with medically sound advice in just plain, simple language. And what this creates is a huge win-win. For patients, it's kind of like having a personal health assistant on call 24/7. It can help with symptom checking, give you medication reminders. It's amazing. And for us, for providers, it's an incredibly powerful tool that can scan through years of clinical notes in seconds to give you a perfect summary of a patient's history. This frees up so much of our cognitive bandwidth, letting us focus on the complex decisions that really require our human expertise. So we've seen AI helping one patient at a time and helping one clinician at a time. But what happens when we apply that same data crunching power to an entire population? Well, that's where AI is absolutely transforming public health. And believe it or not, our ability to predict the next big disease outbreak. This table really says it all, doesn't it? Traditional public health surveillance, it's like reading yesterday's newspaper. It's reactive, it tells you what already happened. AI-powered surveillance, on the other hand, is predictive. It's analyzing real-time data from news reports, social media, even airline flight patterns to forecast where a disease might be headed next. It is literally the difference between reporting on the rain and forecasting the hurricane. Okay, let's pull our focus back inside the hospital again, because AI's role isn't just clinical, it's also operational. It's helping to solve the unbelievably complex logistical puzzle of just running a modern medical center day to day. Think about it. A hospital is just this constant flow of people and resources. And as this chart shows, AI can help optimize all of it. By predicting admissions and discharges, it can make sure beds are available. By forecasting a surge in flu cases, it helps with staff scheduling so you're not caught short-handed. It can even predict when an MRI machine needs maintenance before it breaks down. This is like the invisible nervous system of a smarter, more efficient hospital. And that brings us to our last and honestly our most important section. We've seen just how powerful these AI tools can be. But at the end of the day, they're just that, tools. Their ultimate value, and more importantly, their safety, depends completely on the wisdom and the critical oversight of the human expert. It depends on you. So the big question is, are these systems a perfect solution? The answer, and I want to be very clear about this, is a hard no. And for you as future clinicians, understanding their limitations is every bit as important as understanding their power. As the slide lays out, we have to be vigilant. First, let's talk about dataset bias. An AI is only as good as the data you train it on. So if that data underrepresents a certain group of people, the tool might make really dangerous errors for those patients. Then there's the black box problem. This is where the AI gives you the right answer, but we have no idea how it got there. For clinical safety, that's just not acceptable. And this is why physician oversight is absolutely non-negotiable. I want you to remember this. These tools are here to support your decisions. They never, ever replace them. The final call is always yours. As you all move forward in your careers, you are going to be the generation that truly weaves AI into the fabric of medicine. Your job won't just be to use these new tools. Your responsibility will be to understand them deeply, to question them constantly, and to serve as the ethical guides for how they are implemented in your hospitals and clinics. So I'm going to leave you with this question to think about. As you step into your future roles, how are you going to champion the safe, the effective, and the equitable use of this technology? Because making sure that these amazing tools benefit every single patient, that is the ultimate goal. In our next explainer, we'll continue this by exploring more of those benefits across all of medicine. Thanks so much. In the previous chapter, we examined the clinical precision of diagnostic AI, detailing how computer vision models identify tumors on radiographic scans with high accuracy. That diagnostic precision sits in stark contrast to the daily operational reality of modern medicine. Physicians face overflowing emergency waiting rooms and an overwhelming web of electronic health record documentation. An electronic health record, or EHR, is a digital version of a patient's comprehensive medical chart. The physical toll and sheer velocity of this systemic strain are pushing the clinical workforce to the edge of collapse. Recent survey data from the American Medical Association reveals that 93% of physicians report experiencing symptoms of professional burnout. The World Health Organization officially classifies burnout in the ICD-11 as a severe occupational phenomenon resulting from unmanaged workplace stress. The ICD-11 is the 11th revision of the Global Standard Diagnostic Manual for Health Information. Artificial intelligence offers its most immediate life-saving potential by rescuing the clinical workforce from systemic collapse. The core of this issue is administrative drag. Physicians currently spend up to 2 hours on EHR tasks for every single hour of patient care.
This burden causes pajama time, a routine where clinicians complete medical documentation at home, eroding their work-life balance and accelerating exhaustion. The operational counterparts to diagnostic computer vision are natural language processing and machine learning. Natural language processing, or NLP, gives computers the ability to understand human text and speech, while machine learning, or ML, allows systems to learn from data to improve performance. These systems ingest massive amounts of unstructured human conversation and messy clinical data, analyzing the patterns to extract accurate medical context. While computer vision recognizes patterns in pixels, NLP and machine learning recognize patterns in clinical workflows to automate the administrative busywork. The emergency department serves as the primary, high-stakes filter for hospital resource allocation. Traditional manual triage systems rely heavily on subjective human assessment. Standard protocols like the Emergency Severity Index, or ESI, and the Manchester Triage Scale, or MTS, are clinical algorithms used to categorize patient acuity. During peak volume hours, these manual systems frequently break down, leading to cognitive fatigue among triage nurses and dangerous admission delays. AI predictive modeling addresses this by ingesting complex variables like vital signs, lab results, and past admission histories in real time. The algorithm assigns predictive risk scores to instantly reprioritize the patient queue based on objective data. This dynamic reordering operates continuously without fatigue, far exceeding human cognitive limits during a sudden patient surge. AI transforms emergency department triage from a static, reactive waiting room into a dynamic, predictive safety net. We can see the efficacy of AI triage in real-world applications, such as the massive retrospective study conducted at St. Antonia's Hospital in the Netherlands. Researchers utilized an extreme gradient boosting model to evaluate admission probabilities in 10-minute intervals. Extreme gradient boosting is a machine learning algorithm that builds decision trees sequentially to minimize prediction errors. This horizontal bar chart compares the median time required to make an admission decision between a human-only workflow and an AI-assisted workflow. Evaluating the human-only decision time, it takes a median duration of 151 minutes to assess and admit a patient. Looking at the AI-assisted decision time, that median duration drops down to just 20 minutes, saving an average of 111 minutes per patient on correct admission decisions directly reduces emergency department overcrowding and improves patient mortality rates. Moving from the hospital floor to the outpatient exam room brings us to the biggest driver of burnout, the clinical encounter itself. The computer keyboard has become a physical and cognitive barrier between the physician and the patient during visits. Ambient AI scribes remove this physical and cognitive barrier entirely by turning human conversation directly into structured clinical data. Ambient AI operates proactively and intuitively, providing a distinct capability from standard dictation software that merely converts speech to text. The ambient scribe passively listens to free-flowing, non-linear conversation to extract the underlying medical context. The system autonomously generates a perfectly formatted SOAP note for the physician to review and approve. A SOAP note stands for Subjective, Objective, Assessment, and Plan, which is the standardized format for documenting patient visits. This technology shifts the physician's cognitive load away from data entry, restoring active, empathetic, face-to-face patient care. Does this ambient technology actually reduce the 93% burnout rate we discussed earlier? A recent study published in JAMA Network Open tracked 1,430 clinicians at Mass General Brigham and Emory Healthcare over 1 month. JAMA Network Open is a peer-reviewed medical journal published by the American Medical Association. This line graph tracks physician burnout rates, initially isolating the reported data from Mass General Brigham. Following the deployment of ambient scribes, the hospital recorded a 21.2% absolute reduction in burnout prevalence among its staff. The researchers also evaluated individual physician well-being at Emory Healthcare. At Emory, there was a 30.7% absolute increase in clinicians reporting a positive impact from their documentation practice. While automating clinical notes improves billing efficiency, the technology's primary value is in restoring career sustainability to the medical profession. Relying on algorithmic systems introduces severe risks because AI models are only as objective as their training data. When training data contains past disparities, the model develops historical bias, commonly referred to as the equity blind spot. As a result, algorithmic sorting can systematically filter out specific patient populations, rejecting them based on flawed evaluation criteria. The primary cautionary case study for this failure occurred with an Optum healthcare risk prediction algorithm. The Optum algorithm erroneously used a patient's historical healthcare costs as a proxy metric to determine their actual medical need. Because marginalized groups historically faced systemic access barriers that resulted in lower healthcare spending, the system systematically under-triaged Black patients. Deploying AI without rigorous fairness audits actively automates and scales existing health disparities. Mitigating these risks requires managing AI as a complex socio-technical system. A socio-technical system is an environment where patient safety depends entirely on how the algorithm interacts with human behavior, daily workflows, and institutional governance. Algorithmic validation is highly contextual. A triage model trained on emergency department data cannot be blindly trusted in a general practice setting without revalidation. This necessitates strict regulatory frameworks, ongoing surveillance, and safety dashboards to monitor for model degradation over time. These guidelines are closely monitored by the Food and Drug Administration, or FDA, the federal agency responsible for regulating medical devices and software. Artificial intelligence functions as an intelligent teammate that absorbs administrative shock, augmenting rather than replacing clinical judgment. A physician's ability to understand, critique, and collaborate with these systems will define the safety and efficiency of their future practice. But before a patient even reaches the triage desk, how are they interacting with AI from their own living room? In the next chapter, we will explore the rise of AI chatbots and autonomous virtual assistants in telemedicine.
All right, everyone. So in our last chat, we really dug into how AI can help streamline workflows and tackle physician burnout. But what happens when we flip that lens around and point the technology directly at the patient? That's what we're talking about today. The rise of AI-powered chatbots and virtual assistants and how they are completely reshaping telemedicine. Let's dive in.
So here's our game plan. We'll kick things off by framing the big communication problem these tools are trying to solve. Then, we'll introduce the AI itself and look at what the evidence actually says. After that, we'll get critical and talk about the risks, see how it's being used today, and finally, wrap up with what all this means for you.
You know, before we can even begin to appreciate a solution, we have to have a really solid grasp of the problem. And in healthcare, that problem so often boils down to a communication gap. Honestly, just getting access to care can be one of the biggest hurdles for everyone involved. This quote just nails it. I mean, put yourself in the patient's shoes for a second. You're feeling sick, you're anxious, and what do you run into? Busy phone lines, appointments weeks away, and just fragmented communication. And these aren't just minor annoyances, right? They can genuinely lead to worse outcomes. This is the exact void that technology is starting to fill. So how can technology possibly help with this? Well, I think the absolute best way to think about these tools is not as a replacement for clinicians, but more like a new kind of colleague, a digital colleague, if you will, that can handle certain tasks and free you up for the more complex human-to-human work.
The secret sauce here is something called conversational AI. It's all built on natural language processing, or NLP. And really, you can just think of NLP as the AI's ability to read between the lines. It's what allows a computer to understand not just words, but the intent and context behind our messy human language, and then spit back a response that actually makes sense. It's pretty amazing. And it's not some kind of black box magic. It works like this. A patient types in something conversational, like, "I've got this sharp pain in my chest, and my left arm is feeling kind of numb." The NLP engine just springs into action, pulls out those key symptoms, and then instantly cross-references them against a massive database of medical knowledge. From there, it can provide triage advice, maybe something urgent like seek immediate medical attention, or something more routine like helping to schedule a visit.
Okay, so that's the concept. But let's move away from the theoretical and get into the real world. I mean, it's one thing to talk about potential, but what is the research actually showing us? How are these things performing out in the wild?
This chart gives us a fantastic bird's eye view. And you can see it right there. The biggest slice of the pie is triage and symptom checking. These chatbots are becoming the new front door to the health system. But look at the other big chunks too. Patient engagement, handling administrative stuff like scheduling, and even providing some forms of mental health support. 94.2%. I mean, just let that sink in. That is an incredible number for diagnostic accuracy. Now, we have to be super clear. This is in a controlled research setting, right? Not the chaotic real world. But it proves that when these models are trained on really high-quality data, their triage accuracy can be right up there with human clinicians. And the impact goes way beyond just being accurate. We're seeing a 25% drop in costly hospital readmissions, probably because these tools help with post-discharge follow-up. We're also seeing patient engagement shoot up by 30% and wait times fall. These aren't just numbers on a chart. They represent real, tangible improvements in patient care. Now this is one of the most fascinating and, frankly, counterintuitive findings out there. How on earth can a machine be seen as more empathetic than a person? Well, the AI's empathy isn't emotional. It's about consistency and availability. The AI is there 24/7. It never gets tired. It never sounds rushed. It responds instantly. And for a patient who's feeling scared and vulnerable, that constant patient support can feel more empathetic than a 5-minute chat with a clinician who's juggling 10 other things. But, and believe me, this is a huge but, with all this incredible potential comes very significant risk. These tools are far from perfect, and this is exactly where your clinical judgment becomes more critical than it has ever been. This is the question. This is the one that should give us all pause. You know, making a mistake is one thing, but making a mistake while sounding completely authoritative and confident, well, that's a whole different and much more dangerous ballgame. This quote from a really sobering study out of Mount Sinai is, well, it's pretty chilling. Researchers literally made up medical conditions and fed them to chatbots. And the AI didn't just stumble, it doubled down. It created these elaborate, convincing explanations for diseases that absolutely do not exist. This phenomenon is called hallucination, and it is a massive vulnerability. And to put a number on that danger, one evaluation found that up to 13% of responses from some of the top chatbots were deemed clinically unsafe by doctors. Now, a 13% error rate might not sound catastrophic until you multiply that by millions of patient interactions a day. Then it becomes a very real threat to public health. So we're walking a tightrope here. On one side, you have all this amazing potential, better access, more efficiency, higher engagement. But on the other side, you've got these huge pitfalls, confident misinformation, the risk of algorithmic bias baked into the data, massive privacy concerns, and a super murky legal landscape. I mean, who's liable when an AI gives bad advice? These are the tough questions we're all facing. Now, despite all these risks, don't think for a second these tools are just stuck in a research lab. They are being integrated into clinical workflows right now. But the key word is carefully. The whole focus is on finding those low-risk, high-impact jobs for them to do. And here are some awesome real-world examples. Duke Health has an AI concierge in their patient portal. A lot of health systems are using virtual assistants just for scheduling and FAQs, and it's cutting their call volume by a ton. There are AI-powered screeners for mental health that are incredibly accurate. And for clinicians, voice assistants are slashing documentation time in half. You see the pattern here? The focus is on support and administration, not on making autonomous diagnoses. And that brings us to what I think is the single most important takeaway for all of you. In a world where these tools are everywhere, what is your role going to be? Here's the bottom line. You are the human in the loop. You are the final safeguard. AI is a tool. A remarkably powerful one, yes, but it's a tool like a stethoscope or an EKG. It cannot and it will not replace your clinical judgment, your humanity, or your ethical responsibility. Your job is to guide it, to validate what it tells you, and to make sure it's being used safely and ethically for your patients. And you know, this ability for AI to understand language, it doesn't just stop with one patient. When you scale that up, when you go from analyzing one person's symptoms to millions of data points from across a population, it gives us a brand new way to look at public health. We're moving from the individual to the epidemic. So next time, we're going to explore how platforms like Blue Dot used AI to sift through news reports and flight data to actually spot the COVID-19 outbreak days before it was officially announced. We'll see how these predictive models are becoming absolutely essential tools in public health. I'll see you then.
We have examined how artificial intelligence optimizes individual patient care, from radiology to personalized genomics. Now we zoom out. To manage disease at the population level, we must look at how AI applies to epidemiology and outbreak prediction. Historically, public health surveillance operates on a reactive loop. Health departments monitor for outbreaks by tracking lagging indicators, specifically confirmed laboratory diagnoses and hospital admissions. This creates a critical mechanical failure known as the lag time problem. Viral and bacterial pathogens transmit between hosts at a speed that consistently outpaces the local clinic's ability to process paperwork and finalize lab results. By the time an emergency room registers a spike in atypical symptoms, and those cases are confirmed and reported, community transmission is usually widespread. The reporting system is effectively documenting history, not current reality. Traditional compartmental models, like the SIR model, which stands for Susceptible, Infectious, Recovered, a mathematical framework used to simulate how diseases spread, struggle to account for hidden variables during this lag period, such as asymptomatic travelers moving through transit hubs. Relying strictly on clinical presentation guarantees that public health responses will always be weeks behind the actual spread of the pathogen. Predictive algorithms do not wait for a diagnosis. Instead, they continuously scan for early warning signals to identify where the next infection will emerge before the first patient even enters a clinic. They achieve this by analyzing digital exhaust. Digital exhaust is the massive trail of unstructured, non-traditional data humans generate daily through routine digital interactions and physical movements. The primary advantage of an AI model is its capacity to detect non-linear relationships within this massive, noisy data. It can link an uptick in internet searches for fever remedies to a subtle shift in regional mobility patterns that human analysts might overlook. No team of epidemiologists could manually aggregate and cross-reference these disparate datasets in real time. The volume of unstructured data is simply too high for manual review. This transitions epidemiology from a retrospective counting exercise into a proactive forecasting engine. To understand how these systems operate, we have to look at their underlying architecture. They are designed to fuse highly structured clinical records with the unstructured chaos of digital exhaust. This flowchart illustrates an AI outbreak alert pipeline. Diverse data is pre-processed, then feeds the AI model engine where machine learning detects anomalies. The engine generates a risk score, plots the threat on a geospatial mapping layer, and disseminates the findings to health agencies. This pipeline effectively automates the triage process for global public health, providing the lead time required to secure supply chains and allocate hospital resources. We can see this pipeline operate in the physical world by examining its specific data inputs. Environmental sensors provide one of the earliest indicators. In wastewater-based epidemiology, AI time series models, like ARIMA, a statistical algorithm used to forecast future data points, analyze viral RNA loads in municipal sewage. Because infected individuals shed viral material before feeling ill, wastewater data can predict hospital case surges up to 3 weeks before patients present with symptoms. Simultaneously, systems utilize natural language processing to interpret human text. It scans global news, ER triage logs, and social media posts, searching for early clusters of symptom complaints. This is how the Blue Dot algorithm successfully flagged the COVID-19 anomaly days before official World Health Organization reports were published, by synthesizing travel data and regional news reports. To track movement across mobility networks, AI calculates infectious path centrality to identify the specific social nodes where an infection is most likely to spread. By mapping these complex mobility pathways in real time, the AI identifies high-risk individuals and locations that act as superspreader nodes, particularly for diseases characterized by high asymptomatic transmission. Fusing these modalities allows AI to render a high-resolution spatiotemporal map of transmission that traditional static epidemiological models simply cannot achieve. However, predictive algorithms possess severe operational vulnerabilities. They are tools built on existing data ecosystems, and they inherit the flaws of those ecosystems. The most immediate threat is algorithmic bias. If trained on data with a lack of digital data points, it generates inaccurate predictions for marginalized communities. This leads to misdirected medical supplies and exacerbates existing health disparities, directing resources away from communities with limited digital visibility. There is also the black box problem. Complex deep learning models may output an alert, but they cannot always explain the mathematical reasoning behind that alert to a clinician. Furthermore, synthesizing mobility data with electronic health records raises profound privacy concerns regarding compliance with regulations like HIPAA and GDPR. To mitigate this, engineers deploy federated learning.
It is a decentralized machine learning technique where the algorithm travels to the local hospital servers to train on the data, rather than moving sensitive patient records to a central database. AI systems do not replace the epidemiologist. It acts as a tool that requires strict human oversight and validation to ensure its outputs are equitable and accurate. For the practicing physician, the integration of these systems is imminent. National surveillance networks are beginning to synchronize directly with hospital electronic health records. Soon, your daily workflow will include a hospital dashboard displaying an AI-driven localized risk map for emerging outbreaks in your specific region. These real-time alerts will prompt you to adjust your differential diagnoses on the fly, long before the first infected patient walks through the door. Your role is to understand the algorithm's inputs, to respect its outputs, and critically evaluate its potential for bias. Clinical judgment remains the final word in disease management. In Module 4, Chapter 5, we will examine how hospitals manage physical resources once the predicted influx of patients arrives.
All right, welcome back, everyone. So last time we were looking at the really big picture, right? How AI helps us track and predict disease outbreaks across entire populations. Today, we're going to zoom way in, from that macro scale right down to the hospital floor. We'll be exploring how AI is becoming absolutely essential for managing a hospital's most precious resources. So let's start with a really important question that kind of frames our whole discussion. When we hear about a capacity crisis in a hospital, is that really about a lack of physical space, or is it actually a lack of information? Well, a lot of the evidence is pointing to the idea that the real bottlenecks, long waits in the ER, delayed surgeries, they aren't just because we've run out of rooms. They're often symptoms of information breakdowns. And that is exactly the kind of problem AI is built to solve.
So here's our game plan for today. First, we'll talk about this big shift from chaos to control. Then we'll dive into something called the AI Command Center, look at the intelligent supply chain, and see how AI is optimizing the operating room. Of course, we have to talk about the limitations and the absolute need for clinical oversight. And we'll wrap it all up by talking about what this means for you as a future-ready physician.
Okay, let's jump right in. Section 1, From Chaos to Control. And I love this subtitle, Shifting from Reactive Firefighting to Proactive Intelligence. That really is the whole story here. It's about using data to get ahead of problems, to prevent the fires before they even start. To really get why this matters, let's talk about something called operational friction. Just think about this for a second. Clinical staff can waste 20 to 30 minutes of a single shift just looking for basic equipment like an IV pump or a monitor. Now, multiply that by every nurse, every doctor, on every single shift. It's not just an inconvenience, it's a massive drain that directly delays patient care and, honestly, is a huge reason for burnout.
So how does AI help? Well, it introduces this concept of proactive intelligence, and this is so much more than just a better search tool. We're talking about using AI to crunch massive amounts of real-time and historical data so the hospital can actually anticipate demand, predict a bottleneck in the ER, and move resources around before a crisis ever hits. It's a totally different way of managing a hospital.
And the hub for all this proactive intelligence is what's becoming known as the AI Command Center. I think the best way to imagine it is as the hospital's central nervous system. So how does this brain actually work? It's pretty amazing. It pulls in data from absolutely everywhere, the ER, the inpatient floors, the outpatient clinics, and puts it all together into a single live picture of the entire hospital. This means it can see an ER surge coming hours before it happens. It can flag a patient who's at high risk for a discharge delay. It can even help adjust staffing levels in real time to meet the demand it's predicting. Froedtert Health in Wisconsin is a fantastic real-world example of a system that's using this to stay ahead of the curve.
And you can see the impact in the numbers. It's just staggering. Look, with the old methods, predicting who needs a bed is maybe 70% accurate. AI boosts that to almost 95%. And that creates what we call effective capacity. Basically, you get more out of the beds you already have. In one case, it was like adding 30 new beds to the hospital without building a single thing. And most importantly, it cut down on ED wait times by nearly 20%. That's a huge win for patients.
And that brings us to the biggest bottleneck of all, the emergency department. By using AI to help with triage right when patients walk in the door, hospitals have seen a 20 to 35% drop in the total time patients spend in the ED. This is a game changer for getting the sickest patients the care they need faster.
Okay, so we've covered managing patients in beds. Let's switch gears and talk about managing all the stuff, the equipment, the medications. This is our third section, the intelligent supply chain. It's all about getting the right materials to the right place at exactly the right time. I mean, the traditional way of doing this feels almost ancient now. You had staff literally walking the halls with clipboards, making educated guesses about what to reorder. The AI-powered method is a world away. We're talking about cameras using computer vision to automatically track inventory and smart algorithms that can predict you'll need more of something based on upcoming surgeries or even flu activity in the community. It's the difference between guessing and knowing.
Take a look at this flowchart. This is how complex a manual pharmacy workflow can be. Every single one of those boxes is a step, and every step is a place where an error can happen. AI just slices through all of that complexity. It automates and predicts, which dramatically reduces the chances for failure and makes sure medications get where they need to go.
And the financial impact is huge. Hospitals that have put in computer vision systems to track their assets, cameras watching equipment instead of people scanning barcodes, they've reported up to a 30% cut in operational costs. And that's within the first year. That's a return on investment that no hospital administrator can afford to ignore.
Now this is what I find really fascinating. AI helps solve two problems in the pharmacy that seem like they're complete opposites. It reduces stockouts, running out of a drug you need, by over 40%. That's incredible. But at the same time, it cuts the amount of money lost on expired inventory by a third. So you have what you need when you need it, and you throw less away. It's a true win-win.
All right, let's move on to what is probably the most complex, high-stakes, and financially critical environment in the entire hospital. Section 4 is all about optimizing the operating room.
So, traditionally, scheduling the OR has relied on surgeons estimating how long a surgery will take. And let's be honest, that's incredibly difficult to do, and those estimates are often wrong. That can cause a whole day's schedule to fall apart. AI completely changes the game. It analyzes historical data for that specific surgeon doing that specific procedure and creates a prediction that's way more accurate. It's replacing a good guess with hard data.
And that optimization goes way beyond just the schedule. This quote from Harsha Garadia at Census is great. He talks about AI as a co-pilot in the sterile processing department, the SPD. That's where all the surgical tools get cleaned and reassembled. Computer vision can help a technician correctly identify one instrument out of thousands, making sure the surgical trays are perfect. That's a huge boost for both efficiency and patient safety.
Okay, so we've talked about all this amazing potential. Now it's time for a very important reality check. Let's move to Section 5, Limitations in Clinical Oversight. And I really want you to remember this subtitle. It's maybe the most important takeaway today. The AI is a co-pilot, not the pilot.
Because look, putting these systems into place is not easy. You need good, clean data, because garbage in always equals garbage out. We have to be really careful that these algorithms aren't biased. Trying to get them to talk to existing, often ancient hospital software can be a total nightmare. And most importantly, and the literature is very clear on this, there is an absolutely non-negotiable need for human oversight. A clinician must always have the final say.
And that brings us to our final section, which is really all about you. It's about becoming a future-ready physician and understanding why knowing this stuff is a brand new core clinical competency. Here's the bottom line. The environment you will practice in is going to be shaped and defined by these intelligence systems. How your patients get a bed, how your OR gets scheduled, how you get your supplies. AI is going to be in the background of all of it. So understanding how it works, that's not an IT skill. It is a fundamental clinical competency for your generation. So today, we've really focused on how AI can optimize the whole hospital, the entire system of care. But that brings up a really exciting question. How do we take that same power, that same intelligence, and bring it from the command center right down to the patient's bedside? Well, we're going to explore that exact question in our next session. Module 5, The Benefits of AI in Medicine. Thank you all so much for your attention today, and I look forward to seeing you in the next lecture.
Artificial intelligence isn't just helping us diagnose anymore. It's helping run the entire system, from triage to workflows to public health. And this is where things really start to change, because once systems become smarter, outcomes follow. In the next module, we'll break that down, the real-world benefits of artificial intelligence in medicine, and why this shift matters more than ever.